Good afternoon, and welcome to Boltbird and Kemp's webinar series, Growing with a Spinal Cord Injury. Before we get started, please kindly note that this session is being recorded. Your cameras and mics have been turned off. This is our final session in our webinar series, with our focus today being on therapy considerations in children with spinal cord injury. We are very grateful today to be joined by two speakers, Cecilia Daly and Samantha Higgins. Both are at the Royal National Orthopaedic Hospital in Stanmore. Cecilia is a physiotherapist and Samantha is an occupational therapist. We are very grateful, therefore, for them to join us today and to share their knowledge and experience with us. Thank you for joining us. Over to you both.
Welcome everybody, and thank you, Rhiannon, for inviting us to speak today. As Rhiannon said, I'm Sam Higgins. I'm the occupational therapist at the London Spinal Cord Injury Centre at Spinal, and I'm joined with my colleague Cecilia Daly. The aim of our webinar really was to provide you with information and guidance on children and young people who have sustained spinal cord injuries through traumatic or non-traumatic means, and the therapy input that we provide to them as physiotherapists and occupational therapists. I think it's really important that we try to get across to you that sort of our role within the Spinal Cord Injury Centre, both on an inpatient and outpatient basis, and how we interact with the community services. We're going to talk through different functional levels of spinal cord injury and the key milestones of ages that we'd apply to that for our rehabilitation. It's important to remember throughout the talk, please, that all children are very different. All children will achieve milestones at different ages, but we do use those key milestones, developmental stages, to tailor our therapy as a basis. You know, everybody will achieve things at different ages and different levels and to different degrees. Some children may have sustained some comorbidities within their injuries. They may have some pre-existing conditions. So, you know, it's very much tailored to a textbook functional spinal cord injury as opposed to, you know, individual children. Having said that, we did think it would be useful so we may ask you later on for some feedback on just through the chat, so that, you know, what ages children are. Do you have experience of working, of attending a spinal cord injury centre or through outpatient therapy? It would just be useful for us to make sure that we're tailoring the talk to meet with the expectations. We understand that our colleague, some of you may have attended the webinar by our colleague Jan Goronsky a few weeks ago. I understand that he was talking about medical considerations for the children and young person with a spinal cord injury. We're hoping that our presentation will follow on nicely from Jan's, and we will try not to make it repetitive. And yeah, we hope that it would be a sort of natural progression from medical management through to therapy management within our MDT service here at the Spinal Cord Injury Centre. So as we mentioned, Cecilia and I are both clinical leads for physiotherapy, occupational therapy. Whilst we work within the children's service with our paediatric patients, mainly we both also work with the adult patients within the Spinal Cord Injury Centre service. Which is really useful. We've both been here for a very long time, I think too long, 20 years or so each. And, you know, it's important that we've got that experience of adults as well as children, and, you know, children turn into adults. So we're lucky enough now to see some of our children that have moved from little tiny children through their whole development into our adult services. And we still see them now, which is lovely. On our children's ward, we have 3 beds allocated to our patients at any one time. And as I said, we're very much tailored to a wider MDT. So we have a reintegration practitioner who works with their patients sort of on a daily level. She may do things like school visits, taking them out on social outings to the cinema, shopping, accessing public transport, all of those services. And we work with 2 clinical nurse specialists, a psychiatry, psychology team, dietitians, orthotists, and obviously our medical colleagues. So that sort of forms the basis for the multidisciplinary input here. We're hoping that we can give you a bit of an understanding of our intervention as therapists, and I think we're probably focused on the key areas, because we could talk to you for days about children with spinal cord injury and you'd probably all get very bored. So yeah, we're just going to try and focus on some of the key areas where we see the most complications potentially, the ages at what children are at risk, and we can go from there.
So on to the assessment. So quite often if your child gets to a spinal cord injury unit or happens to be at one of the trauma centres or DTH, there's an awful lot of assessments that get completed. So just thought it'd be useful just to understand what assessments we complete, and also why we complete them, because quite often these are completed really early on after your child sustains a spinal cord injury, and you're receiving so much information that sometimes trying to retain or even hear what people are saying is really quite difficult. So the assessments that we complete are top to toe really. So your respiratory assessments, range of movement, your ASIA, proprioception, we'll go through. It's a fancy word, whether you know where things are in the world, spasticity, muscle power. It often takes time to complete all of these, and it's not unusual that they might take, you know, over 5 sessions or even more that we complete all the assessments that we need to do. And we know it is often frustrating, because if you've come to a spinal centre from another hospital, you may find that your rehab has been paused and, you know, we've had these assessments done before, why do you need to redo them? So they are really important. And if any of you happen to be on Dr. Gronsky's talk a few weeks ago, he spoke of the analogy of the motorway, so understanding complete and incomplete injuries. And now if you think of that in a little bit more detail, that each lane on the motorway is responsible for doing a different task within your body. So the inside lane might be the lane that tells you, I need to use my muscle in my arm to bend so I can bring a drink to my mouth. The middle lane might tell me if the water is hot or cold. So all the assessments we do look at every pathway within your spinal cord and helps us work out where the messages are getting to. So we do appreciate there are an awful lot of assessments, but they are vital to us knowing how we can tailor your child's treatment, but also anticipate if there are going to be any issues or complications that may arise. So the ASIA and INSCA, you'll hear these words bandied. ASIA is the old-fashioned word, so that's the American Spinal Injuries Association. It was reclassified a very long time ago as INSCI, which is a very wordy international standards of neurological classification within spinal cord injury. It's very long. So people still use ASIA or INSCI, and it can get confusing because both of them essentially mean exactly the same thing. It's really important because it determines the level of spinal cord injury and whether the injury is complete or incomplete. And that's when in the United Kingdom, the doctors will do the testing around your sacral segments, so the segments around your bottom, and they might do the rectal examination depending on the age of your child. But it's the only way in which you can make a standard and an international standard to say whether your injury is complete or incomplete. ASIA can be completed in children in the age of 8 and older. Younger than that, we can use other things and other adaptations like the wee step assessment, or can they feel hot or cold? We usually use ice because children are quite innate in their reflexes in this bit. But again, it can really inform us about complications. Next slide, please. So the respiratory one is a really important one. And this is where the assessments will tell us. So once we've completed your ASIA, depending where you can feel or not feel or anything like that, that will give us an indication of actually what muscles might be working and what not be working. So a couple of the respiratory assessments that we try and perform, if your child's able to and if they're old enough, and you know, all those other considerations, is vital capacity, which is a really simple, as big a breath in as you can and you blow out as hard and fast as long as you can. But that is a really important indicator of what muscles are working and whether or not your child is likely to fatigue, and they might just need a little bit of extra support. The vital capacity assessment requires coordination. It's quite tricky for adults. So if your child isn't able to do the vital capacity assessment, then we can use a peak cough flow, and that's a simple mask that you put on your face and you ask the child to cough. So it doesn't really require coordination, but it is a really nice indicator. And we can preempt if a child is likely to be respiratory fatigued. And that's what we really want to do. No one wants your child to deteriorate even further when they're there. Next slide, please. Thank you. So the assessments also are your upper and lower limb assessments. So what we've spoken about before is range of movement. Does your child, when they arrive at the hospital, have full joint range of movement? So would they be as expected for their age? Do they have some more? Do they have a little bit less? And it's really important to perform the baseline assessments, because that will give us a really good indication of what we can do, and making sure that nothing changes whilst they're actually having rehab or in hospital. The proprioception is a really fancy word. It basically means whether or not you know where things are in the world. If I move my hand to my mouth, I know my hand is moving upwards in the world. If I'm sitting, I know roughly how much my knee is bent. And they're all really important in knowing how to move as you go through the rehab process. Spasticity is a really tricky one, because immediately after the injury, or you get your child sustains their spinal cord injury, they're unlikely to have spasticity. And then over time they may, and it can affect everywhere. So it can affect your arms, your legs, but also your trunk. And it's often mistaken for activity. My child can move their arms, they can move their legs. And actually spasticity is not a movement in which you have control over. And that's often very tricky to manage and understand. But with education, it's really important to be able to distinguish between spasticity and actual selective muscle activity, because as therapists, we would want to inhibit spasticity and try and utilize any selective activity. What we really wouldn't want is for people to use spasticity early on in their rehab to perform any function or tasks. And motor power is how strong is your muscle? And it doesn't mean they have to have big muscles or anything like that. They can have little flickers, but it just informs us, like I said, where the messages are getting to, how we can tailor your rehab program, and just get the most out of your rehabilitation. Next, please.
Posture. You will hear the word posture all the time during your child's journey through rehabilitation. It is probably one of our most important areas that we focus on. And I think, most people's understanding of posture would be, oh, am I standing well? Am I sitting with my back straight? If you have a spinal cord injury, if you're having to spend long periods of time in certain positions, or you're unable to naturally correct your posture, you're at huge risk really of complications. So we refer to posture as a 24-hour management program. It's sitting in the wheelchair, it's laying in bed, it's overnight, it's standing, it's playing, it's going to school. Posture is everything really. Without optimal posture, your ability to perform day-to-day tasks is compromised. It might be that if you're not sitting in a good position or standing in a good position, you're going to use your arms differently, your legs differently, and that's placing unnecessary strain basically through other joints. For example, if I was to sit for long periods of time, nice and slumped, and I'm trying to push a wheelchair for long periods, or put my hands up above my head, I'm using my shoulders in a very different way to I would if I was supported and sitting well with some gravity helping me. So it really is important that we get that. We know that 100% of children who acquire a spinal cord injury before the age of 5 will go on to develop scoliosis. More than 90% of skeletally immature children with a spinal cord injury will develop a scoliosis. That's the majority of our caseload. That's the majority of our children with spinal cord injury. And that's one of the reasons we like to see people here throughout their journey of their childhood, key points of ages, basically. We know that children and young people who acquire a spinal cord injury before the age of 12 are more likely to require corrective spinal surgery for such scoliosis. So it's huge figures, and that's a huge proportion of our children that are going to have their function impacted by their posture. So from day one, 24 hours a day, we try and manage posture as well as we can, particularly through key growth spurts. And we'll go on to talk about this later, but we try and see our children here as outpatients within a multidisciplinary clinic after their initial rehabilitation every 6 months or so, sometimes a bit more frequently, sometimes a bit less. But that is to try and capture those periods of growth. So it could be, well, the wheelchair fitted really well and that had a really supportive backrest 6 months ago. You're 13 years old and you have a huge growth spurt. That changes very quickly, and the wheelchair services just don't have the capacity to monitor patients in that way. So we can sort of do an overview assessment and then liaise back in with the community teams. The other thing it's important to say about posture is if you're not sitting equally through your pelvis, you're quite likely to develop pressure sores, places you're at more risk of pressure sores, skin deformity, joint structural deformities of your bones, and then that's so much harder to correct. So it may be we put certain things into cushions in wheelchairs to try and help manage habits that are developing or asymmetries within the posture, and we'll work very closely with educating parents, children, families, community teams about that as we go through the process. These photos here show different postures, and if you think this is postures that a child has developed over time, but if you just try and sit for a short period, say through your left buttock more than your right, or with your right buttock rotated forward, or with a big exaggerated curve in your spine, within, I would say, I don't know, a minute, most of us are thinking, oh, do you know what, that's hurting the left side of my hip. I need to adjust my posture. So we know that. We get told that by our feedback, our sensory feedback, and we will automatically adjust that. The same is true overnight. If we're laying on, your elbow, for example, it's quite quickly your fingers will go numb, but we know that, so we will change that. People with a spinal cord injury don't get that feedback necessarily, so they're not developing that awareness, and they're going to struggle then to know to change their position. So that becomes a responsibility of us therapists, educating them, educating the parents about managing their posture. It may be, I think you may want to move on to the next slide. The right wheelchair. Oh,
one back.
Yeah, one back. Sorry if that's possible. Yeah, wheelchair setup, so important. So this is the same child. You can see how they're sitting with the pelvis down on one side, and they've got that curvature through their spine. The wheelchair, so I'm never happy with a seated position in a wheelchair, so I'm always critical, but she's fairly level in her pelvis. She's sitting fairly symmetrically, and that's all through to either wearing a postural brace, which we recommend for all of our children, a supportive backrest, a right appropriate setup of a wheelchair. If a wheelchair isn't set up properly, then their child isn't going to be able to play as they could with their peers. Going to school is going to be more difficult. Engaging in day-to-day tasks is more difficult. So it's really important that that is considered throughout the growth process and throughout a lifetime, really, with spinal cord injury. But more importantly, with children, that we do it at key intervals and regularly. Over to you, hip flexors.
And so hip flexors are also really important. If a child and young person spends the majority of their day sitting in a wheelchair, the hip flexors are the muscles that go across the front of their hips. So when anybody, whether they have a spinal cord injury or not, are sitting, those are in the shortened position. When you're able to get up and move around, then the muscles move from being short to then being put on a stretch when your leg's behind you when you're walking. If you're going upstairs, the leg that's behind you is, you provide it with a really nice stretch every time you do stairs. The pictures here are really interesting from a therapeutic perspective, because the picture on the left is a child and young person that has spasticity, but the two pictures on the right are from a child and young person that actually has no spasticity at all. So their legs are flaccid, they don't have any involuntary movements, there's no tendon jerks or anything. But what happened with the person on the right is, if you spend all day in your wheelchair, which is your main means of mobility, and that's what your expectation is, that then you can go to school. If you then don't do your stretches, and if you don't do your home exercise program, and if the child isn't able to stand, and that may be because there's not room at home for a standing frame, or one hasn't been provided, there's so many other factors that can influence this. Structures without spasticity can also get tight, because I know it is a common myth, in everywhere, not just with parents, but within professionals within major trauma centres, that if you don't have spasticity, then you can't lose range of movement. You absolutely can. The two pictures on the right show really quite clearly that actually this was 3 months post-injury. So this young person left us with full joint range of movement, flaccid lower limbs, so no spasticity, and they came back, and this now they present with a real significant loss of range of movement. The child on the left has spasticity, and this is the position then that their legs could get into. It occurs relatively quickly. So apart from going on about, we go on about everything. I think you'll find with every slide, it's really important, and we go on all the time. But shortening of structures, so fibers within your muscles and tendons, happens relatively quickly after a spinal cord injury, which is why even when you come with us, or you go to another spinal centre or your trauma centres, you're given stretches and things to do, and it's really important that they're done just to keep the length of all the muscle fibers, keep the joint integrity, that they're completed every day or advised by your therapy team. Most young people aren't really interested or care about how their hips present or their scoliosis until they hit teenage years. And then all of a sudden, as per, I'd like to generalize, a lot of teenagers, aesthetics become really important. They're exploring relationships, exploring how they look, and all of a sudden, hip flexor contractures are really important. So they may have had these from years and years and years, and it's just something they've accepted. But all of a sudden, when you get to a teenager, they don't want them anymore. At this point, there is no reversing of this with stretches. The muscle belly, which if you contract makes that nice bicep shape, that's got much shorter, the tendons have got longer. So for any change to be affected here, we need surgery. These muscles attach usually over two joints. The hip flexor muscle doesn't just go across the hip, it goes all the way down to the knee. So it often involves really complex surgery, which also may not achieve what the young person wants it to achieve. Having hip flexors that are short can also affect someone's sitting posture. It can really affect where your pelvis is, if your hamstrings are tight as well, so the muscles behind your legs, if they're pulling your pelvis backwards or even forwards. There's so many different variations on this. Or, as these both do, they may sit beautifully to anyone that walks past. Next slide, please.
Okay, so we, as I mentioned earlier, I wanted to talk to you about through the ages really, and what are the key issues at certain injuries, at certain ages, what are the key focuses of therapy during those periods. We're hoping that everyone on the call, that you'll have a child that will fit somewhere between this, but we do pretty much cover from newborn up to 18, so hopefully there'll be some useful points for you. And children with a spinal cord injury, we need to support them and encourage them to follow the developmental pathways of their peers, of other children at 5, 10, 15, whatever. And it's really important that we tailor rehabilitation to those key areas. We'll talk about it more as we go through, but essentially through our review clinics, we may highlight key transitioning periods. So actually, child's going to secondary school in September, but they're still quite dependent on mum for personal care, but mum's got to go back to work, so she's not going to have time to help them with that in the mornings. Okay, so we may readmit people for short periods during those periods to work on specific goals. It might be for a week or 2 weeks to think, right, okay, I need to be fully independent with my morning routine before I go to school. Okay, what about when I get to school? How am I going to get around? So it may be secondary schools are much different to primary schools. So all these key things that we'll talk about as we go through the next few slides. On to the next slide, please. Thank you.
So 0 to 6 months. So relatively young newborn babies up until 6 months. So these very young babies respond to external stimulus. So everyone that's ever come into contact with a newborn baby, you touch their cheek and they'll move their head, well, I try to, but it's all innate reflex actions. So at this developmental stage, it's really important that if your child sustains a spinal cord injury, to think about posture and bracing, positioning. You know, when a child is sleeping at this age, most babies like to sleep like a frog. So their knees are bent up and they resemble a little frog. But if you think back to where I spoke about the hip flexors, babies at this age, although most new mothers will not agree, tend to sleep for anything up to 20 out of 24 hours, although sometimes I'm sure it feels like your child is awake for 24 hours, but most children actually sleep for 17, 18, 19, 20 hours out of a 24-hour period at this age when they're very young. So if they're sleeping for that long and their knees and hips are like a frog, then the muscle that goes across the front of the hip flexor, will be in their shortened position. So it's just making sure that actually the exercises are done. Even when they're asleep, you can move their legs. Toy placement, as the child progresses in the age through this developmental milestone, they become closer to 6 months age. Children love exploring with their hands and their feet, and they'll like to stretch out if they're able to. So it's making sure the toys aren't always placed on the same side. And it's really important, if your child is in a cot, that not all the toys are always placed in one direction. It's quite tricky in hospital, if your child is in hospital during this age, because depending where the cot is placed, the child will often lie looking towards the same way all the time. So if the door's always on the left, the child is always placed in that direction. So quite often we'll say, put the foot to the head end so the child looks at different ways. Make sure the toys are placed on both sides. Even if that happens to be the side of the cot that goes up and down, it's really important that the child gets stimulus from both sides of a cot. Often if your child is ventilated, doctors are very, very careful with their ventilator tubes, and they tend to always be positioned one way. But again, if a ventilator tube is positioned one way, you're limited then in the movement that the child's head can get, or their arm may be able to explore. So it's just making sure that the child has the opportunity to explore as much movement as possible for their arms and legs during this age. We go to the next slide. So this one is when they should meet, again, their developmental milestone. So, the posture and bracing again. So if your child is sitting up and exploring, and at this age, often children start to pull themselves up. So if they're by a table or a sofa, children of this age group will actually try and pull themselves up. So this is often where, if you're with us during this time, we will explore getting a standing frame for your child. If your child is in the community, then we'll liaise with the community teams. The feedback we often get is, well, your child isn't standing, or may have never had the opportunity to explore standing, depending when they got the spinal cord injury, or our protocol is a child needs to be able to achieve A, B, and C for them to have a standing frame. So it's just a conversation quite often that we'll have with the community teams to say, actually, developmental milestone between 6 and 12 months, a child may at this age be able to pull themselves up into standing. So we need to provide the opportunity for these age of children to be standing as well. It's a splinting, your child may need splinting, because again, as we've spoken about before, everything is optimal alignment, and it's the posture, the shoulders, the trunk, the spine, everything, hands, fingers, toes, it literally is head to toe management. And everything is as important as anything else that we have spoken about. Advice on sitting posture. Sam will often liaise with the teams and the parents regarding buggies and car seats. As with any child, again, of this age, playing on their tummy. So tummy time, but it's really important for these children. If you think, again, hip flexors, I mean, we go on about probably everything all the time, but it's really important because if they're playing on their tummy, their hip flexors are in a really nice position, so they get a really nice stretch at this time. Next slide, please.
Okay, so around 1 to 2 years, our children would be getting more mobile. So, you know, maybe they're bottom shuffling, it may be they're crawling, some children are walking, most children are walking between this age group. Okay. This is really frustrating, you know, for our children with spinal cord injury, because big sister's playing over there, they can't get there. So we might look at standing frames with the facility to have sort of wheels on. It may be that we'd be looking to refer a child to the wheelchair service at this age. And that seems awfully young, and that's often the response I get from wheelchair services when I phone them. And they're saying, well, we don't see them till they're 3. Well, that's fine, but actually, you know, your pushchair from John Lewis doesn't have the postural support in it that a child needs. It's not going to give them the ability to get from A to B across the room. But you could look at sort of adaptive pushchairs and powered devices that would give them some more freedom, give them the ability to engage with their peers. So I will usually start to broach that subject with the parents around that age. I think, you know, we're thinking about gross motor movements. They're going to, you know, start to try and get to places. Well, most people will favour either the left or right side. So at this age, we might be thinking about postural braces to use in sitting, if they're playing on the floor, tummy time, crawling, sitting in the pushchair or the buggy or the wheelchair. So we'll be liaising with our orthotics colleagues for that. It may be they have lower limb splints, hand splints, our tetraplegic patients. You know, at this age, we would be beginning to engage in more dexterous tasks, picking up a gross grip with a crayon or a pen, throwing things, those activities that, you know, that's going to be impacted. So how can we facilitate a child engaging in those activities? So we'll be looking at splints and devices and equipment to support them with that. We mentioned earlier about toy placement. If a child favours one side all the time, we need to be thinking, right, we're going to put the toy on the other side, just to try and keep things symmetrical. Can we move on? Thank you. On to the next slide.
Yeah, so this age, again, it's more the exploring the standing frames. Again, like Sam said, with the wheels, you can get the rabbit upstanders. We don't have any affiliation to the company, but they're great. They're big wheels. Children can stand in them and they can push themselves around. They can go outside to play, you know, in their garden with their siblings if they have them. At this age as well, we'd encourage them to start practicing transfer technique with help from mum, dad, carer, guardians. It's always quicker and faster to just pick them up, and we appreciate that. And everyone's time, there's so many demands on time. And whilst, I mean, at this age, they're frustrating and they don't listen all the time anyway. But actually, if you can start to practice the techniques and functional development, then actually they will learn their independence and they will be able to progress within their milestones. So, you know, probably not first thing in the morning when you're trying to rush out and you're being called in a million directions, but this is where we would ask with the community teams, can we practice their transfer technique? And the feedback is usually, actually, the children love it. They love gaining independence. They love the positive feedback, that rather than just being picked up out of bed, put in their chair, you know, and vice versa, that they're actually helping themselves. Again, lots of playing on their tummy, so lots of playing in prone lying. If the child is able to, in high kneeling, and quite often we'll suggest to parents just to buy toys and things that they can do in high kneeling. Again, it not only helps the hip flexor, I mean, that seems to be on every slide, but it is really important. But if they've got any muscle activity, something in high kneeling, so even if their muscles around their feet don't work, actually they can work their tummy, they can work their core, they can work their bottom muscles. So it's a really sneaky way of making them do exercises, but in a really fun way. So working at sand tables, water tables, or anything like this. So quite often we'll liaise with nurseries as well and say, can the activities that the children may be standing and playing with, can they as a whole group do them all in high kneeling? Because actually every child would benefit from developing really good alignment, really good muscle activity, really good, power. So, this can be undertaken by a whole group. The child doesn't have to be isolated as the one child at nursery that has to kneel at the water table. All the children can do it. So we usually get really good cooperation from nurseries about actually the whole class do the same thing. Again, it's really encouraging the age-appropriate developmental milestones. So if your child has the stability and they can sit on a trike or a scooter, I mean, scooters, every year they seem to bring out a new one that has a new fancy, attachment to it. Actually, even if your child can't pedal it, if they can sit in a scooter or sit in a trike and you push them, why would they not be able to do that? Because actually, if you look at most children that go through the park, age 2 to 3 in a trike, most of them aren't pedaling the pedals. Most of them are sitting there enjoying the view, being pushed by mum or dad. So actually encouraging them and not being scared to put your child in a trike or a scooter. And as Sam had mentioned, referral to wheelchair services. If you should be up and walking at this age and you would expect your child to be up and walking at this age, why then are they dependent and stuck? Because they're not able to get themselves up and walk around at this age. So again, if the developmental milestone is your child is gaining more independence and can, toddle, waddle, run between A and B, this is what we really want to encourage then for the children of this age. Next slide, please. So age 3 to 5 years, delightful age. So between these developmental milestones, most children will then be going to primary school. Lots go to the nurseries, the majority go to the reception class. So this is where the standing frame, what we advocate for and advise is that all standing frames are at school, in primary school. So from when they start primary school, it's usually at reception. So from reception through to year 6, that all standing frames are at school. This negates the idea then that as parents, you have to find the time, because it's really time consuming when they come home from school and they're tired and they want a snack and then they want another snack and then they want dinner. That actually they should be able to stand at school during the day with either assistance from a learning support worker or a TA or someone. But also it's nice for them to stand at school because they can stand with their peers. We really advocate if the child is able to and has arm function activity, that again, the rabbit up stand or standing frame with big wheels, because then the child can stand and move around the school, they can move around the playground. If need be, they can go in the standing frame for PE. So we really advocate that in primary school, all standing frames are at school. It means then you don't have to have a battle in the evening to try and get them to stand, but also they like to stand with their peers at this age. Orthotics, depending, again, they will have had lots of growth spurts up to this age. Making sure that their alignment, because they'll be likely to be standing for longer at school, so they may need orthotics on their feet and ankles just to ensure that their alignment is as good as we can. Again, lots of playing in high kneeling. Again, reception is a perfect classroom. They very rarely do table-based activities, it's on the ground. So they're really well set up if need be, and they make really good modifications to tasks if they're encouraged to or asked to. Walking aids is an interesting one at any age really. So most walking frames that most people are aware of are the ones that go in front of you. The issue we have with the walking frames that go in front of you is they naturally encourage you to lean forward, so they naturally encourage flexion. And that makes it much harder to walk, because actually the muscles that really help you walk are the big extensor muscles, the ones that bring you upright. But if you're bent forwards, the muscles that bring you upright and you use when you're walking are really hard to engage. So quite often we would suggest a reverse walking aid or the K-walkers, the frames that go behind you, because they really encourage you to be really nice and tall. The other things we would say here is encourage participation. So anything at this age that your child should be able to do requires practice, requires time, and time is the biggest hindrance to all of our lives. You know, if your child should be looking at being able to put maybe their socks on, is practicing this within this age group. If they should be able to put their jumper on, is practicing again within this age group. Is how do you put your jumper on? Do you need to put your lunch bag in your school bag for school? You know, or can you get your Wellington boots out to put on? So it's really encouraging them to achieve everything that, you know, a child without a spinal cord injury may be able to do as well. Supervised transfers, again, you know, at this age, they can practice transfers, and it might not just be at home. They now, if they're at school, they could do transfers with the LSA or the TA. You know, at this age, children are really eager for responsibility. They like the responsibility. You know, they know rules, they break rules, so, you know, with supervision, but they really like responsibility. They like learning new tasks. They like all the positive feedback as well. So lots of encouragement. But yes, we do appreciate it places an awful lot of stress on your time to achieve all of these with your children. Next slide, please. So if I start this one, so this one, again, 5 to 10, so they're still at primary school, so the standing frames will be at school. The orthotics is the same, you know, your child will have had yet another growth spurt. The walking aids, exactly the same. The age-appropriate play activities is, you know, at school your child should participate in PE. One of, I'd say our bugbears is children that get taken out of PE to do their stretches or their physio. No child should be taken out of PE to do stretches. Your child needs to do PE. It's their development. It's a great social activity. You know, we're trying to encourage everyone to lead healthier lifestyles, you know, to grow a love of sport, not necessarily to go and compete, although we do have Olympians that have come through our centre, but actually just from a cardiovascular perspective. And if you're always taken out of PE and then you may get to secondary school, you may never go back into a PE lesson again. So your child shouldn't be taken out of PE. They shouldn't miss break. They shouldn't miss lunch just to have their stretches done. Stretches can be 2, 5 or 10-minute sessions throughout the day, and they can vary the times. And maybe you miss 5 minutes of maths, 5 minutes of English, 5 minutes of story time. Or what we have found is lots of primary schools are really open to, if the school day starts at 8:50, if your child gets there for 8:40, they can do their stretches in that 10 minutes. But we really advocate that your child goes to school and participates in all the school activities throughout the day.
Just to add on to that, really, I think with going to school around that age, obviously children go through a lot of changes between 5 and 10. They're moving from their sort of early years at school, key stage 1 on to key stage 2, changing relationships with friends, and with that, social activities. So thinking about, okay, well, my friends are going to Brownies that night. How am I going to get to Brownies? How am I going to liaise with my family are going to liaise with the brown owl? So it's looking at accessibility in other places as well. You know, a child shouldn't not be able to go to Brownies in the same way they should not be able to go to PE, and making sure they've got the right equipment and care support to help them to fulfill that, really, and to fulfill their things they would want to do anyway. Just to retouch really on personal care activities and baking and things like that. Children love doing things in the kitchen with mum around this age. They want to make a cake with you. So would they need potentially some equipment to help them with that? A chair that might be able to bring them up to a higher height, or a lowered surface in the kitchen, to be able to do that with mum. Dressing and washing, depending on the level of spinal cord injury. You know, we can look at splints and adaptations to help a child to hold a toothbrush, for example, with a higher level of tetraplegic injury, or a lower level of injury. Okay, well, I can't sort of balance on one leg to get my trousers on. So we can show them different ways to do that, and different ways to get their levels of independence we would want them to achieve at that age. Move on to the next slide, please. Because as you're kind of going from 10 into the adolescent years, you're transitioning from primary school to secondary school, and we've in the last couple of years seen a lot of, particularly our girls, struggle with that transition. And I think it's really important just to sort of mention that going to year 7 is hard enough. Okay, you're moving your safe environment where you've probably got a one-to-one teaching assistant, one-to-one support worker potentially, and you're going to a great big secondary school with a totally different environment, thousands of children, not hundreds of children. You might be separated from your main support network, your main peers at secondary school. Getting around is going to be a lot harder. You know, it's not just straight out of the classroom. They've got a nice little ramp for you onto the playground. You know, you've got to get from classes all over the schools. PE will be different. We've got to look after their shoulders around this age. You know, they've got a lifetime spinal cord injury. If they're pushing themselves around at primary school all day, that's, you know, that's manageable. By the time you get to secondary school, we really need to be looking at powered wheelchair power add-ons. Even for our high functioning paraplegics, we would recommend that to look after their joints in the longer term. They're not going to want for a support worker to take them to the toilet if they need to. They're not going to. A lot of our children will complain. We strongly advocate most children get to leave lessons a bit early to travel to the next class. They don't want to. They don't want to leave earlier than their peers. They want to be able to go in the corridor at high traffic time. So we need to sort of liaise with the schools, and obviously they have their risk assessments in place, but making sure they're safe to do that, and they've got the equipment to help them with that. During the adolescent years, they're going to want to be going out independently to the cinema. They're going to be going, they might want to look at skiing or something like that with their friends, things their other teenage friends are doing. It's important that they keep fit and active. And as Cecilia mentioned, you know, we've sort of encouraged participation in PE throughout school life. And other sports may be of interest to them. We'll mention at the end, but we work quite closely with Backup and other charities. I'm not sure if anybody's heard of Backup, but they're excellent at sort of providing peer support, going into schools, educating schools. They often host assemblies quite often before a patient would leave here, before their initial rehab. If they're going back to secondary school, Backup will go in and do an assembly, or sometimes they choose to do it together with the child. Whatever works for each individual, but it's important that we focus on those things, get them as much independence as we can towards that. Towards the end of that period, can we move on to the sorry,
just for the adolescent years, if you think this is often when they have their like intellectual activity develops, and this is when a child that either has or doesn't have a spinal cord injury will really challenge you as parents, as adults. You know, they begin to establish their own values and beliefs, you know, and this is normal within the adolescent years. So if your child has sustained a spinal cord injury prior to this time, you know, and has done all of their standing, all of their stretches, and suddenly you hit the adolescent years, and, you know, we hear it quite frequently, you know, they won't wear their orthotics, they'll no longer stand. And this is often the age that when they get to year 7, because the standing frame transitions from school to home, because obviously within a secondary school they move around classrooms, that the child stops standing, because trying to find time in the day when they've got home after school to stand. And what we try and advise is that if the standing frame has a table, that they can maybe stand for, you know, half an hour and do the homework in standing. But this is the time that the adolescent brains are developing. The part of their brain that is risk taking, wants to really push the boundaries, is much further developed than the part of the brain that actually makes your sensible choices, your executive decisions. And you know, that, as everyone involved in the care of any adolescent, whether they have a spinal cord injury or not, will experience at home. You know, don't give up at hope. You know, by the age of 25, everything will have developed equally, and every part of their brain on the whole should have caught up. And as Sam said, the fitness thing, you know, if a child has been taken out of PE lessons in primary school, to then expect them to all of a sudden go and join in, you know, PE lessons at secondary school is really hard. You know, you're going through so many body changes. Like I said, your emotional parts of your brain are really overactive and are much more, well, in one way more developed, because they give you higher highs and lower lows, you know, and trying to know how to, you know, regulate those, or being able to regulate those is really difficult. But like Sam said, backup are brilliant. Most governing bodies of sporting organisations will happily provide schools with someone that can go in and teach. And so the British Tennis Association will provide coaches to go in and coach. You know, the Athletics Association do. So if schools will reach out or parents reach out, I would say probably 99% of sporting organisations will happily go into schools to enable the participation of all students. So it doesn't have to be those that have a spinal cord injury, it can be anything at all, but they're really, you know, really happy and they're really eager to establish themselves and help within the school in process. Most gyms nowadays offer youth sessions. So when children quite often get to year 9, quite often on the way home, lots of groups now go to the gym. They have youth sessions every evening. You know, a general chat with the local gym, or go in and meet the gym. You know, when they're purchasing new equipment, most gyms that are council owned are really open to, actually, if that bike now needs replacing, we could replace it with a recumbent bike, or we could replace it with an arm cycle. So they're really receptive to requests, but the requests have to be made. So don't be frightened or scared to actually speak to others and ask them. Because actually, if we can establish, you know, arm cycles in a gym, you know, as a normal part of a gym equipment, you know, everyone would benefit from it. We all know if we use our upper limbs, we increase our heart rate. So they're really easy to do. Thank you. Sorry, next. Next slide.
Okay, so 18, wow, big age. Okay, you're going to be wanting to drive. Okay, so that's achievable for a lot of our patients. Okay, so we need to think about driving lessons. Just because you have a paraplegic or a tetraplegic spinal cord injury doesn't mean you're not able to drive. There's driving assessment centres which we would recommend, just to ascertain as to what hand controls may or may not be required, or any adaptations for the cars. Getting into the driver's seat, so just looking at potentially different vehicles. But we would recommend that our children, rather than just going for a driving lesson with even for our walkers with an automatic vehicle, maybe they go to an assessment centre, have a good, you know, trial of all the different adaptations that are there, and work out off-road with a specialist what works best for you. You're going to be wanting to get independent with all the meal preparation, domestic tasks, and this is more sort of main meal preparation, survival, not just helping mum baking in the kitchen. You might be going to university, need to think about accessibility at university, contacting the universities. Again, that's something backup is great at, and most universities are really receptive to recommendations. I think the key thing to think about though is, you know, there's even less support available. You know, you think at primary school you're likely to have a one-to-one, that may reduce during secondary school. University, well, you're off alone. So actually, if you have a level of injury that doesn't allow you to achieve those things with adaptations, you might be looking at how am I going to get the right support at uni? How am I going to get that property with the right adaptations, the right shower, the right care support? So that's really important, and something we can guide our patients with. Socialising with friends, well, they're going to want to go clubbing and to festivals and all of these things. So we need to make sure that the equipment we have supports that. So, you know, it may be we need to look at more all-terrain options with manual powered wheelchairs, camping, whatever it is they want to achieve. There are things that we can explore with them, going to different venues. You know, it's one thing going to the cinema with your teenage friends, it's another thing going to Wembley to watch a massive concert. So it's just making sure our children and their parents are are prepared for the levels of independence around that. You might be wanting to go on holiday with your friends rather than your parents. Okay, so we're thinking about how we can support with that, you know, looking at companies. There's Try Before You Fly, there's specialist travel agents that will be able to explore equipment that might be needed. And whilst that's relevant throughout the child's growth, it becomes more difficult when you're going alone, or when you're too big for dad to pick you up and carry you into the apartment that hasn't got the right accessibility and that kind of thing. So it's really important that we address that with our children as they transition into our adult services. I think, you know, we'll just sort of mention that we are a lifelong service, so our children will naturally progress to the adult services, but the level of support they have from the MDT will change at 18. So we're still here, we'll still see them as outpatients, but they don't have that 6 monthly follow-up. And they're seen by the consultant alone in clinic and then referred into different therapies as needed. So we're kind of preparing the child and their family for that in the last few years of their adolescent life as they transition into adulthood is really important. There's a big change, and in the community as well, between adult and children's services, and I think that's quite a challenging and terrifying step for a lot of parents. So it's making sure that all those referrals are made early on, that we have all the right support networks in place. Was there anything else you wanted to add to that?
No, I think the summary part is just the developmental milestones, so the next, that's it. And just things that, you know, should be worked on, you know, depending on your child and their level of spinal cord injury, you know, may be achievable. So that's a really nice summary of just everything that actually we would look at, you know, trying for your child to obtain. And then, yeah, no, just the home and what next, really. It's, you know, if you're under the care of the Spinal Cord Injury Centre, what do you have? And it, you know, differs wherever you are, really. But yeah, just back into the world after, quite often it's quite a long time in hospital as well, isn't it? So, you know, your child may be in hospital for, you know, quite a long time at their major trauma centre or district general before you come to a spinal cord injury centre, or your child may be at a cancer hospital and actually may have a spinal cord injury for quite a significant length of time before they're well enough to even access or, you know, be able to attend an outpatient appointment at a spinal cord injury centre. So there's so many variables to what can happen, and what support is available, really. That's it. Questions?
Thank you very much. There are some questions that I will just put to you, and then that I also have for you. So in the chat, someone has asked, how many hours a day do they need to wear the brace that you mentioned?
So that is, so it's child specific. So your therapy team and your orthotist will guide you. But if you think of when we're sitting, as we're all sitting now, if we are all sitting, we are all able to sit up against gravity, because on the whole, all of our muscles that support us in sitting work. So even if you've just got a couple of muscles that don't work as efficiently or strongly as they should, gravity will pull you down into a less than optimal posture. You know, if you think of how babies sit, they're very flexed or they super arch, just because at that point the muscles around their tummy don't work. That's why, you know, babies have lovely big bellies, because none of their muscles have developed. So it's usually guided by your therapy team. It quite often is all day whilst they're up. It may also be at night time as well. If your child has hip flexors that are a little bit tight or short, depending which word you like, then we'll quite often get them to wear their brace at night and lie on their tummy. Because if you lie on your tummy at night or any time in the day and you don't have a brace, you just compensate at your back. So your hip flexors don't get stretched, you just get a really nice deep curve in your back. So usually quite a long time, but you have to build up because of your skin tolerance and things.
And on a similar topic, we've got a question: what are the braces you use made of?
They're the spinal braces. We call them dependent on what part of the body they're for, but like TLSOs or LSOs, but they're made by our orthotics department by a high temperature thermoplastic. So the child will usually go to plaster theatre with the orthotist to be cast for the brace, and then that will then be made in their clever engineering department in orthotics into a high temperature thermoplastic, and then fitted to the child by our orthotist, who would have assessed them in clinic with us or on the ward with us.
Perfect. And another question, do you do tendon lengthening?
We don't. No. So where we are, obviously the Royal National Orthopaedic Hospital, yes, our orthopaedic surgeons do, so do many other orthopaedic surgeons. So, but if you think of tendon lengthening, is it the tendon you want lengthened, or is it the muscle belly, or is it something we can prevent before we get to that stage?
So we'll quite often liaise with our orthopaedic team, or our consultants will, if we think that surgical opinion is required, and then they will assess them and form their own recommendations from that, and then we'd obviously need to see again to adapt any of the other equipment you've got accordingly, depending on what they do.
Okay, and another one, do you make seated corsets?
So again, we'll do assessments with our orthotics departments, and sometimes as an alternative to braces or for different reasons, we might recommend a corset in sitting. It may be a soft corset, sometimes it's a reinforced corset, but yeah, we do sometimes recommend them dependent on assessments. I think generally we tend to find at the moment the hard braces work better, but corsets are an option, and sometimes lycra garments as well.
The corsets quite often are if the child does a lot of sport. So if they do a sport where, you know, they need an awful lot of trunk movement and ability to move their trunk, they quite often, the orthotics department will make them a strutted corset, so they wear that just whilst they're undertaking the sporting activity. Perfect.
A couple of questions that I had for you. In terms of kind of weight management and the impact, I suppose it links into the physical activity and the impact on wheelchairs. Do you find that sometimes wheelchairs are having to be changed more frequently because children are either putting on weight or losing weight? Does that, how the impact of that?
Yeah, it can do. I think the weight changes, you know, do happen intermittently. We do have support from a dietitian, but certainly with regards to the wheelchairs, growth can happen within weeks as well, either way, so length or width.
Yeah.
And chairs do need to be frequently reviewed, more frequently than with our adults. You know, often with an adult, you know, the wheelchair service, I think they tend to say 5 years unless clinical need changes. Well, with our children, that's why we see them so frequently in clinic, so we can capture any changes like growth or weight gain or loss, and adapting the chair accordingly, or changing chairs. So they will need more frequent replacement than certainly than adults, and regular follow-up.
Yeah. And how much do you link in with kind of local authorities? Because we've seen that, you know, some local authorities, talking about your accessibility to outside activities like play parks and things, are now, you know, some of the playgrounds are having adapted equipment within the play parks. Do you liaise much with local authorities that there's someone being discharged into the community who's a child with a spinal cord injury, so they can look at what provisions are in, or is that just too much to expect in busy clinicians?
We would liaise with the community occupational therapy teams who might be based within so it's not just about the community rehab teams for housing adaptations or equipment provision, it would more be social services therapists, and they would have links with the local authorities, so that would be something that they would usually follow up in the community. I think backup can often help there as well if people are experiencing difficulties with local authorities, but I like to think, and I hope that generally with most new pay equipment, that is something that's considered within the local authorities with their team of therapists. Anyway, but you know.
Yeah.
We have in the past, so local to here, there was 2 new leisure complexes that were built. And here we're very fortunate. Our swimming pool has a ramp that goes down into it, so there's no hoist, you just go on a shower chair. And we tried really hard to get the ramps at both of these swimming facilities, which are both within 8 miles of here. Neither were successful, but both pools do have hoists. So lots of pools, probably again the majority of council owned pools will have a hoist, but most people don't realise they have hoist because they're never out on show, they're always put away somewhere. But again, if you go and you say, I know you have a hoist, even if you don't know, just say you know you do, because they will do. It'll just be put in a storeroom somewhere, and it will be there. And there's a really large sports village up near the University of Hertfordshire, and their hoist is never put away now. It's because it's so well used, because people know it's there. But yeah, no, we did try with the 2 new sporting complexes, really huge, and that was a miserable fail. Apologies.
I think when liaising with leisure centres and things, you know, as well, it's reminding them that staff changes is quite high, and with that it might be they haven't got the confidence to use the hoist or even know what it is, and that's why it's shoved in the cupboard. So it's just kind of refreshing memories and trying to get them to train people appropriately within their complexes.
But most gyms do have accessible equipment. I have to say most are really receptive. If they're getting rid of equipment or the contract or the lease is up, they will quite often get equipment that is able to be used by both able and non-able bodies. So, you know, that's a real positive move forward for the gymming world.
Yeah. Okay. Victoria, did you have anything?
I did. You mentioned that you're finding that girls especially are finding the transition from primary to secondary quite challenging. I just wondered whether you had any insights into or theories as to why that might be.
I think I mean, this is my opinion, our opinion probably. It's just something we had a run of with a group of our sort of patients that we see regularly in clinic, and I think it is it's, as I said, it's a difficult time anyway. Girls are particularly, and boys do, but girls more so, we seem to find, don't we, tend to have more challenges within their friendships around that age, and more of a dependence on maybe 1 or 2 peers rather than bigger groups of peers. And they become more self-conscious. They're more aware that they're in a wheelchair and it's harder for them, it's different for them, they might have to have somebody with them. And I think that's the sort of key areas. You know, there's a lot of anxiety around going to school, to secondary school. It's scary. And we're just seeing that enhanced, I think, in our year 6 to 7 transitions at the moment. And maybe it's to do with COVID as well, actually thinking about it, because they've had periods of time within quite key developmental milestones where they would have been isolated and restricted from their peers. So they might have smaller groups of peers that they're then transitioning to secondary school with. I think there's lots of things, and you know, but it all sort of comes together. But certainly we do seem to have had a run of it over the last couple of years.
I think what we haven't seen though is it doesn't appear to be a correlation between how long they've had their spinal cord injury. So it seems to have been, I mean, near 100% children, girls that have moved from year 6 to year 7 have had issues, but there seems to be no correlation. We've had some that have been injured since they were babies and others within, you know, the previous 6 to 12 months, and there doesn't seem to be any differences between the issues that they all experience.
Interesting. Thank you. Perfect. Well, thank you very much, both of you, for joining us today. It was an excellent and informative session that will provide invaluable information to either children with spinal cord injuries or those that support those with spinal cord injury. That now brings to an end our webinar series on children with spinal cord injuries. The spinal team at Bolt, Bird and Kemp are really grateful to all of our speakers for providing their time during this seminar series and enabling us to provide resources and information in this under-resourced area. Thank you everyone for joining us.
Thank you for asking us, inviting us. Thank you very much.
Thank you. Bye-bye.
Thank you. Bye-bye.
Bye.